So thanks for all the people in the room, and I can't tell how many people are online. Vicky?
21.
21, all right, so we got about 40, 50 people listening, that's great. So it gives me great pleasure to introduce Alex Kral. As some of you know, he's been a longtime collaborator of mine. So I've seen the story. You know, he's really doing among the most important work in the harm reduction space. It has been for a long time, but really the last 10 years, he's honestly been on fire. His work on the unsanctioned drug consumption site somewhere in the United States. He's followed that up by being the lead investigator on the Measure 110, I guess now debacle in Oregon, fortunately, and is doing a bunch of other work related to the National Syringe Service survey and other good and meaty work that will help advance hopefully our understanding about how to improve human health. I did have one little tagline I wanted to say about him, which is, you know, in science, we often think of ourselves as in the business of discovery, which we are. But sometimes we're in the business of discovering how we might have a better world. And from my perspective, that's the thing that Alex really brings to the table and why I'm so honored to have him speak with you today. Dr. Kral.
Thank you. Thank you, Dr. Bidenthal. Great to be here. Thank you for inviting me to come here to the Institute for Addiction Sciences at USC today. As the title says up here, I'm going to be talking really about overdose prevention sites, going through the global and domestic research policy and implementation of these sites. And figured I would start, see if I can hit the right buttons here. Just with a brief little introduction of sort of where do we place overdose prevention sites? They're really within overdose, within harm reduction, and when we think about harm reduction, we're really talking about a set of practical strategies and ideas that are aimed at reducing negative consequences associated with drug use. Doing that client directed, doing it non-judgmental, doing it in a non-punitive way. And really coming up with practical strategies and interventions. These principles and the kinds of work that's happened over the years has really evolved. And I think the first thing that's really important for everyone to think about is that every single harm reduction service that we have seen or that has happened has really first been contextualized by and implemented by people who use drugs themselves, and usually in hostile, unsanctioned environments. Some of the initial strategies focused on some practical low threshold things like syringe service programs or drug checking strips. And it's really evolved to a more explicit focus over the last couple of decades on centering and empowering people who use drugs. You know, the naloxone distribution programs are certainly part of that. The drug users unions, both in Europe and now they've been starting in the United States lately as well. These overdose prevention sites, which we're going to be talking about today, and also community-based drug checking programs, the drug testing programs as well. But I think it's also good to think about the fact that these programs really are under attack, and they are under attack because the people who that they're trying to serve are under attack, right? There's a lot of stigma associated with drug use, and really every harm reduction intervention that's out there has been met by really a series that starts with first law enforcement having active prosecution of what it is, whether it be needle exchange programs or now the overdose prevention programs we're going to talk about today. And then that's kind of led to, you know, after a few years, some local to then maybe state and hopefully federal, kind of turning a blind eye. They're not actively prosecuting, but they're actually like, okay, we're now going to actively turn a blind eye to the fact that this harm reduction intervention is happening in our community or our state. And then with time comes these sort of local quasi-legal kind of legislation and funding in some of the sort of more progressive cities. And then finally you get to kind of state legislation, and after state legislation, state funding comes after that, and generally, and maybe even some federal funding with restrictions after that. But this process, generally for each of these interventions, is like 2 decades in the United States. Like from then starting something and going through this whole cycle of all these various things takes like 20-25 years. I mean, you look at change service programs, for example, which started in the late 80s. They didn't really get federal funding sort of towards the end of this, until the last like 5, 6, 7 years. It takes a long time for that to happen. And the same is true for all of these things. And so this is a way to kind of look at it. And then once you kind of get this established, then you get sort of the last part of this, which is you will get local reactionary legislation, defunding, active prosecution again in some places as well, and sort of becomes a cyclical thing. But I wanted to kind of address this as that's how things are going in general, to look at that cycle. When we're talking then, like, where are we at with overdose prevention sites, and what are they? What's the state of them? And that's what I'm going to be focusing on today. And essentially what an overdose prevention site is a place where people can use pre-obtained drugs. So they're getting drugs from somewhere else. They can't get them on site. And then they use them there under the supervision of somebody who basically is equipped with oxygen or naloxone at minimum. That's like the sort of bare bones what an overdose prevention site is. So they can help essentially reverse their overdose in case there is an overdose right then and there. Now, there's a lot more that comes to it, but at the sort of, if you strip it down to that, these have been called safe consumption sites or drug consumption rooms, which is what Dr. Blumenthal just called them, supervised injection facilities. These are all the same basic places. And they can be standalone sites, that they can be mobile sites, they can be part of a larger site. There's really a lot of different iterations of these. And they have existed globally for 35 years now, or since the 80s. And they're currently in over 200 cities in the world, and in 15 countries in Europe, Australia, Canada, and the US as well. So what are these sites trying to solve? What's the problem they're trying to solve? Where are we at with this? Well, there's a few different things that sort of have led us to having these kinds of sites. The first is that people who overdose while using drugs alone are most likely to die from an overdose, right? There's no one there to save them, revive them, act upon it in any kind of way. So you don't want people using alone. And even if people do use with others, overdose reversal requires someone to either have a naloxone and be able to use it and want to use it. There's a lot of things that need to happen right then and there. And so what these overdose prevention sites provide is a place to go where someone's going to actively look at you, and someone who's trained in how to save you in case you overdose. So that's sort of the problem that you're trying to get through there. But there's also the other piece, which is that public drug use is a big piece of the puzzle as well. So lots of people are using publicly. That's uncomfortable for both the people who are using drugs. They don't want to be doing that in front of a family walking down the streets, or maybe afraid their police is going to come or something like that. But also for the people who have to witness it. Nobody wants to see someone using drugs in the streets or something like that. And so these are places where you can go out of the public eye of people to use drugs as well. So it gets people off of the streets. And then connecting people to needed social and health services, including drug treatment, is expensive to do. How do you get them in? How do you link them? You can have outreach workers everywhere. It's tough to get people in various places. And so this is also a place where you have an catchment area where people are already coming to you. And so then you can add other services or link people to other kinds of things as well. And then the other piece of it is also just kind of the sanctuary piece that these places provide, because, the streets, there's a lot of violence, robbery, there's a lot of things of exhaustion from people being out there. So it solves some of the homeless, or temporarily, or at moments where they're here. It's a place of respite as well. So where are we at with the current landscape of OPS in the United States? So essentially, and I'm gonna be talking about most of these, and showing some of the evaluations today of most of these. But the first is really, the unsanctioned overdose prevention site that was in an unnamed city, somewhere in the United States, between 2014 and 2020. There were some other documented and still are some undocumented, unsanctioned OPS also in the US. The first government sanctioned site opened on November 30th, 2021. So pretty much 3 years ago, by On Point, New York City. And that's still open. So that's been open for almost 3 years. And there's really 2 sites there, one in Harlem and one up in Washington Heights. And then the only other government sanctioned site was the one in San Francisco, which I'll talk quite a bit about today as well. That existed for about 11 months downtown and on Market Street in San Francisco. And then from a policy perspective, Rhode Island State Legislature sanctioned overdose prevention sites now maybe 3 years ago, I want to say 2-3 years ago. And they're finally going to open their first site in Providence this fall, hopefully the next month or so, I think I'm being told, which will be interesting to see. And then the state of Minnesota last year also sanctioned overdose prevention sites, but they don't have any sites that are kind of actively in planning or something like that we know about that are coming up there. And then there are still other US cities that are in various stages of doing it this other way. And you really have 2 different ways. You have a legislative way of doing this, and then you have just a city saying, we're just gonna do it. And so those are 2 very different things. They have benefits and drawbacks, each of them. The legislative one is good because then it's not sort of, it's not up to a mayor, or you have a change in a mayor or a change in ideas about mayors. That's got some problems with it, but it's also much flexible. You can just sort of decide to do it right away, right? Legislation, takes longer to do. And often then they legislate the kinds of rules and regulations that perhaps sites don't really want to do or aren't optimal for where they are as well. So there's some problems with the legislative sites as well, but there's sort of the 2 different ways that we're 2 avenues really towards getting overdose prevention sites in the US. I'm going to go on to talk about the science piece, but before I do, any questions so far about what overdose prevention sites are, where we're at, anything about that yet, either in the room or online? Yes.
My quick question is and so when it's sanctioned, it just means that they look the other way, right? It's still technically illegal.
Yeah.
But they just unenforced. Got it.
Yeah, exactly. So it's just unenforced. Yeah. So, we don't technically know if these sites are illegal federally because there hasn't been a lawsuit against them per se. There hasn't been anything that's actually actively happened there. But there are aspects of them that are. There's a couple of different laws that are important here. One is what they call the crack house statutes, which actually Biden was the one to introduce in the late 1980s, which is that if you know that there's drug use happening in your where you're in a place that you own, then they can basically seize that house. So if you have a house and people are using drugs in it, they could come and take the house from you essentially. So here we know that there's drug use happening in these sites, and so that's potentially going against that. Now, the argument there is potentially is that the law wasn't intended for public health purposes. It was this sort of like, people are just using drugs on the street in this house. We want to be able to do something about that. So would the law, we don't know. It hasn't been tested yet. So would the law go against that or not? We don't really know. And the other would be the Controlled Substances Act, which is, now 50 years old, or a little over 50 years old. And that is, you're not allowed to use these drugs well, I guess now all states. Back now that Oregon has recriminalized as of September 1. But so yeah, it is technically probably illegal both federally and for most of these states. So they're looking the other. It's part of that sort of cycle of looking the blind eye towards it. Yes.
I have a question online. This is from Dr. Rosalie Piccola from the Schaefer Center. While the US has been slow to open overdose prevention sites, other countries have had them for a bit longer. Are lessons from those relevant for the US, or do key differences in drug markets influence the generalizability?
Yeah, that's a good question. Hopefully I can maybe answer that more with going through some of the science here, because what I'm gonna do is I'm gonna go through kind of quickly the global evidence for these, and then I'm gonna go through the US evidence for this. And the answer is gonna be, at the end of the day, is that you're gonna see the exact same results globally and in the US. So in that sense, we both can learn from them, and it seems like they have the same effects here that elsewhere. And I know when it gets to drug policy and a lot of other policies in the US, it's this sort of US exceptionalism that like, oh yeah, this works in Europe, but it could never work here in the US because we're very, very different. And I don't want to minimize the fact that there are huge differences, especially in terms of how healthcare is delivered or who pays for healthcare in Canada or many of those Northern European countries compared to the US. But that's sort of the payment piece of it. If you do these sites, they pretty much look the same, and they basically seem to act the same, both in the US as they do elsewhere. Okay, so what is the scope of the peer-reviewed science? I'm just gonna go through the peer-reviewed science here. There are, of course, other reports and things, but I'm just going through that. And there really have been, there's been over 100 articles published in the peer-reviewed literature on OPS. Scientists from Europe, Canada, Australia, Mexico, United States, in a variety of academic disciplines, from the social sciences to criminology and law and public health. Lots of different study methods, from quantitative, qualitative, survey, ethnography, cost benefit analysis, a lot of different kinds of methods. And these are, many of them are published in the top, high impact medical journals in the world as well. And what this essentially globally has shown is both, to begin with, and really when I think about the effectiveness of these sites, I think about it on two different levels. The first is, how does it impact the people who go there? And the other is, how does it impact the neighborhood in which they're placed? And I see them as very sort of different parallel lines to how you look at this, evaluate this. And so first, if you look at the impact on the people who use these sites, they've been shown to reduce overdose deaths, to reduce infectious diseases like HIV and hepatitis C, to reduce frequency of drug use, to improve access to both health and social services, and increase access to substance use disorder treatment. Hey, that's pretty good stuff right there. I mean, that's all the things we really want to be doing for the people who come there. So that science is quite strong. In terms of the impact on the communities, they've been shown to reduce public injection and improper disposal of needles in the streets. They've been shown to reduce drug-related crime and violence in the neighborhoods where they're placed, and to reduce the demand for ambulance services for opioid-related overdoses, right? Because they're actually taking care of the overdose in-house, so you don't necessarily need an ambulance to come. Okay, so now we're going to get to the part that I'm going to spend most of my time talking about, which is where we at with evaluations in the United States. I'm going to first talk about the evaluations we did on the unsanctioned overdose prevention site in an unnamed city in the United States. I'm going to briefly talk a little bit about the New York City evaluations, and then our San Francisco site, and then lastly with a little bit of the cost effectiveness research. So basically in 2014, we were contacted, my colleague Peter Davidson at UCSD now, and I were contacted by an agency that said, look, we want to open one of these sites. Would you guys be willing to evaluate it? And so they opened in 2014. They had two separate rooms, one for injection and one for post-injection, to sort of, hang out, if you will, still be there. They had four of them, up to six stainless steel tables. They had a trained staff person who was stationed in each room. They had sterile equipment, disposal of needles, exometer, naloxone on site, and actually towards the end they also had oxygen, and then they had a tablet for inputting data. And doing this project was very interesting. I'm gonna talk quite a bit about that. But what we did was, we did 4 different kinds of research here. The first was we had site data, so just sort of what happens at the site, who's coming, what's going on, is there overdoses happening? We did a quantitative cohort study of almost 500 people who inject drugs in those neighborhoods. And essentially did surveys with them at baseline, 6 months and 12 months later. So it's a cohort study. We did some secondary analyses of crime data from the city. And then finally, we also did some ethnography and qualitative interviews. And this really presented a lot of challenges doing this work. I mean, I've done harm reduction work now, research for 30 years. This was a unique situation for many different ways. The first was, like, we couldn't at any part somehow let people, authorities or police know that there was this underground site, because that was gonna potentially be, detrimental to the people working there. So what did that mean? Well, that meant a lot of different things that we had to think through. The first was, what about the funding agency? So we got funding from the foundation, but we didn't tell them where this was gonna be. Were they gonna be willing to fund something in a city they wouldn't know where it was? And the answer was yes, they were willing to do that. What about IRB protocols? How would the USC IRB feel about, hey, we're doing this study in a place you won't know where it is? On the other hand, does it really matter? I mean, it's the same protocols, whether we're doing this in one city or another, right? And luckily that was the way that the IRB felt at the time. On-site data collection. So we had a tablet for them there, but we basically had to scrub this tablet so that if police came or something like that, they could never know where it came from. And then we didn't want there to be data on this thing that they could get, because this is, potentially incriminating data in some sort of way. And so we had a system of basically uploading. The data was immediately uploaded and not on the thing. And then we had to go to a European country IP basically signed, so it was out of the United States. So we couldn't be subpoenaed about exactly getting the data for that, because it was going somewhere outside the US as well. And so, this is not usually what you have to do to go through to do these kinds of things, but it was quite something to do that. Our communications with program staff, through emails, through texts, who knows what's gonna happen with all of that? So we had to figure out ways to communicate in a clandestine way with them to do that. Survey questions, well, they couldn't be specific to the cities. You couldn't say, hey, look, have you gone to this particular program with a name that's in that city? You couldn't do that sort of stuff. And then media interviews. I think, Pete Davidson and I probably did somewhere around 200 media interviews over the 5-year period. And I gotta tell you, like 199 of them tried to figure out where this place was. And there was like another 100 we didn't do, because the only thing they really wanted to find out, where was it? And they didn't care about anything else. And if we said we weren't gonna tell it to them, click, they weren't interested, right? So how do we, they figured all kinds of ways to figure out how to ask us questions that might somehow divulge it in various different ways. It's like, okay, can we stop playing games now? But there was a lot of that as well. Other challenges are sort of is there perception of bias here? Like, hey, look, if we're protecting this site legally or illegally, are we viewed as being independent, or are we not independent? Are we the site, or are we not the site? That's a big question right there. There's a possibility of personal legal liability involved with doing this work. I mean, we now know, per that crack house statute, we know where drug use is happening. Is that a problem or not? And then there's also the potential loss of credibility. We've been doing this harm reduction research for a long time. We depend upon collaborating with these kinds of programs around the country all the time. What if we messed up on one of these things, or they weren't happy with what we did in some sort of way? Were we gonna lose our credibility potentially, and continuing to do this kind of research as well? So there's a lot of challenges involved in doing this work that I just wanted to put out there, rather than just sort of talk about the results, which is what I'm gonna do now. We had this piece in the New England Journal. Essentially, what it showed was that during those 5-6 years there were about 10,000 injections that happened at the site. There were 33 overdoses. There were absolutely no deaths. And that's sort of the main take home, really, is that, hey, there were overdoses. No one died, right? That's the number one point here, right? The cohort study we looked at things like emergency department visits and hospitalization as well, to look at comparing basically the people who inject drugs in that city. What about the ones who go to the site versus those who don't go to the site? And what's their utilization of health services essentially? And they were, the people who use the site were much less likely to visit the ER, to have, and to be hospitalized, frankly, both of those things, which is a really big piece in and of itself. And then we also looked at other issues like syringe sharing and rushed injections and isolated injection drug use. None of these were actually statistically significant, but the rates were much lower. 83% lower likelihood of receptive syringe sharing. 23% lower injecting in an isolated location, meaning basically injecting by themselves. And 6% lower rates of rushed injections as well. So that's some of the things that we found there. And then looking potentially on what happens in the neighborhoods here, the people who went to this sites had 58% lower rates of the number of improperly discarded syringes in parks and public places like that as well. And then the other piece here, and this is kind of a fancy Pete here, thing that Pete Davidson ran here. This is the crime data. So what we did was we took 5 years of data before the vertical line here. It's 5 years of crime data in the city. And then we have 5 years of data during which this site was opened after that. And we looked at crime data. We had two different sites. And so to the left, you see the green is the 500 meters around the site. And then the blue and then also the red are 500 meters around two other sites that are in a different area of town that are very similar. One is a homeless resource center, and another is an adjacent neighborhood that has got a syringe service site in it. What you see is that actually up until the point that this site was opened, crime was actually increasing in that neighborhood. And what you see afterwards is it actually sharply goes down as compared to these other two sites. The first one in the blue there was essentially parallel the whole time, essentially flat the whole time. There was similar down swing in the other neighborhood as well. But the bottom line sort of, really the bottom line is it certainly didn't make things worse, which is what most people think. There's a sort of honeypot idea here that, hey, if you put one of these sites here, you're going to bring more crime to our neighborhood. That definitely did not happen. So summarizing from the unsanctioned site, then, it helps the people who use them by preventing overdose deaths and emergency department use and hospitalization. And it helps the neighborhoods in which they're in by reducing crime and the syringes in public settings. On to the New York site, and there's a very robust evaluation that's happening there that's led by Magda Serta at NYU. I'm on part of the team, but this is really their work. Early on, even the first couple months, they had a piece in JAMA that just showed that, after 6,000 drug consumption events, there were 54 overdoses, and they were all saved. And I think those numbers are now somewhere above 2,000 saves that have been there, and no one has died in those two sites there either. And then looking at the neighborhood around that, there's another piece in JAMA Network Open by another team. And they basically compare the neighborhoods around the OPCs to neighborhoods that had around syringe service programs that didn't have an OPS. And they found no significant changes with respect to violent crimes or property crimes, 911 calls, or 311 calls regarding drug use or unsanitary conditions. And they also looked at and found that there was a significant decline actually in low-level drug enforcement in the area, as well as significant declines in criminal court summons in those areas as well. And so it really appeared to be good. So far it's looking good as far as that. And now they've got a cohort study funded by NIDA, and an evaluation is ongoing at this point. So now we get to San Francisco. And in San Francisco, we have what was called the Tenderloin Center, or TLC. And this was opened in January of 2022. And basically the mayor declared that made an official declaration that allowed the city to waive bureaucratic hurdles to quickly implement the mayor's Tenderloin Emergency Evaluation Intervention Plan, which include both this center, and it includes increased policing in the area as well. So both of those. The point, sort of her point was, well, you know what, if we're going to create a place for these people, then they have somewhere to go. So now we can police them if they're not going there. Was sort of the idea behind that. But the idea was not to have an overdose prevention site there. So they opened the site. And what happened was within a week, the point there really was to begin with was to have it serve as a linkage to drug treatment. But if you don't have enough drug treatment in your city, do you really need a linkage center to linkage to what? And so, a lot of the things that were sort of levied on the site was that, hey, you guys didn't link enough people to drug treatment. Well, that's not the center's fault. It's the fact that there's not enough drug treatment in the city. So what happened quickly was people came there, they saw what was there early on, and they sort of said, okay, well, it's not, not sure why I need to go here. And some of them started using drugs in the bathroom, which was really unsafe to do. And so Health Right 360, which was the leader, which is a drug treatment program that ran this site, they basically said, you know what, we're going to open an OPS, just right, boom, so it was about a week or so after they opened the site. They said, we're going to start this, and it basically is an outdoor site, and it was on Market Street. It had a fence around it, and then they had a lot of services that ended throughout that year that they connected more and more people to, in doing that. It closed, however, after 11 months because of some of the political backlash to having this particular center there. And so what did we do to evaluate this? Well, we basically wanted to quantify guest use of the site, and we got various different things. But one thing that was that I think was quite innovative that I want to point out is that we wanted to look at the amount of time people actually spent at the site, and then how do you do that? Because it's, we weren't taking people's names, anything like that. And so Pete Davidson, basically what we did was we had these temporary QR code wristbands. And so when they come in, you get this temporary wristband with a QR code, they check in, and then they use whatever services they needed to use there, including the OPS. And then when they leave, they would, check out, and then they could take it off if they wanted to. But that way we could see how much time did they actually spend at the site. So that was one of the things we wanted to look at. We did a six-month-long participant observation ethnography for this, a lot of qualitative interviews, observation notes, etc. And then we did systematic observations of the streets around the TLC and a comparison neighborhood, and I'll explain that those methods in a little bit. Lots of different research questions here about will people come? Will they use these services? Will they, will people overdose? Of course. Will attract people from other neighborhoods again? That sort of thing. And how can the model be improved? So first of all, looking at will they come? There were 124,000 visits in this 11 months period. So that's a lot of visits right there. So clearly they will come. No questions asked about that. People coming to the center at all spent a median of 1.7 hours at the center. That's a lot of time. But specifically those people that checked into the overdose prevention side of it, they spent a median of 2.8 hours a visit on that. That's a lot of time. I mean, you consider like people going to needle exchange often just come up and then they go, they get their syringes and they're off they are, right? They're here for 2.8 hours on median. And in fact, if you look at it, you multiply it out by the number of people who were there, number of visits there, it essentially represented 18,000 hours a month that people using drugs were off of the streets and they were at the site where they were safe and were going to be okay. That's a lot of person hours right there. They had all kinds of other things on site. They had behavioral health, they had housing and shelter support, they had physical health, the doctors there at times, they had social services, and it's a great place to add a lot of different kinds of services here that were being used. The ethnography yielded a lot of different things, and we have this paper here really on radical hospitality, which was what became the idea really the driving philosophy that came there was this idea of radical hospitality, the idea that really the people who come here are guests, and you should treat them as you would a guest coming to your home or house, and make them as comfortable as possible. And that really drove philosophy of how everything happened at this particular site. Also, what we found was that people really liked the one-stop shopping part, that they could go there and get all these kinds of services taken care of in various different ways. And it created a space for community building. They had karaoke there, they had a lot of different kinds of things. Music was always kind of blasting, and people were having fun, and people were really building a community. And a lot of people who are out and about, they don't have that. And this is a space like, oh, we're all here together. They're making friends. They're making connections, meaningful connections with both people and staff there. It was really important. And then, they talked a lot about offering safety and the respite for guests. And one thing that was kind of interesting on this part was this one woman I remember that we interviewed. And she said, one of the things I like about this the most is that when I'm here, I don't have to save anyone from overdose. Like, I don't have to take that responsibility. When I'm out there, I'm always got naloxone with me, and like, I'm always looking around, and I'm like, I gotta like be, worried about, do I need to save people? What do I need to do here in some sort of way? And this is a place where she felt like she could just be and have the professionals take care of this piece. And I think that's what the added piece regarding a respite, I think was an important one for them. There were 333 overdoses during this 11 months on site. Nobody died. And you can see this is sort of by I think this is a week. Yeah, by a week, the number of overdoses, and those things do fluctuate, often because of really drug market pieces. And will it bring people in from other places? Well, for a couple of months, they did a thing where they basically asked every person who came from what neighborhood they came from. 94% of them were from the Tenderloin, which is right then and there. 2% from the adjacent neighborhood, also the other adjacent neighborhood to there. They weren't coming from anywhere else. They were basically coming from right down there. And then the last piece we did was what we call systematic observations around the TLC. So basically what we did again was we took a 500-meter radius around the center. And then we had a comparison site, the Mission Neighborhood Resource Center, which is a center for people who are experiencing homelessness, and they have a medical clinic there and all kinds of things as well, as a comparison. And then what we did was we had 2 research assistants come and walk every single block, and they had a tablet to basically record information on to see what they saw on the blocks. And we had expected there was going to be one of these sites opening in the city already in 2018. And so we started doing these in 2018 and 2019. But no site sort of came up. And then, as luck should have it, when they placed this site, they literally placed it about a block from where it is that we had assumed there would be a site at a future time. And so we actually had pre-data and post-data then for both of this data. We collected things like, do you see people smoking drugs or injecting drugs or selling drugs on this block? You see, needles on the streets, those sorts of things. Also homelessness issues. Are you bringing more homeless people to this area or not? So visible human excrement, people sleeping, tents, those kinds of things we looked at as well. And so what you see here for this data is then the pre-data, which is 2018 and 2019. And then the 2022 data is basically 6 months after this opened, but it's all during the time that this was open here. The bottom line is the control neighborhood. And what you see there is about as flat a line as you possibly can. Basically, the amount of blocks, the percentage of blocks that had these kinds of things at them was completely, did not change over these 3 time periods. But at the top, you see the red one, and actually what you see between 2018 and 2019 is it was actually steadily increasing in this neighborhood, these kinds of, drug-related and homeless related things on the blocks. But then you see at the 2022, again, it came down, and that was statistically significant that it actually came down by then as well. So it's certainly, again, not making things worse in the neighborhood and possibly making them better. So summarizing the findings, from this then, 333 overdoses, no deaths, right? This is the data we see, no matter where we go, wherever you are in the world, this is what you see. On average, 18,000, hours, that people are not on the street. I think that's, per month, that's a lot. The model was certainly appealing to guests. And people will use these sites in San Francisco, and co-locating these other services was something that's important in terms of both reducing barriers, but also connecting people to the kinds of support that they need. There was a sizable need for these sites. They could, I think from a lot of our work there, and we interviewed staff quite a lot. They could use more support to improve staff wellness. I think it's tough to work in these places, doing this work. You are bearing witness to a lot of trauma. And so that's an important thing to think about here. And then the drug use and improperly discarded equipment, was basically the same and even potentially lower as it was in 2019 before that. So our recommendations for this was to open more of these sites, co-locate them with other kinds of services, increase staffing and capacity for this, provide ongoing de-escalation training for employees, implement same-day debriefs too. And I think a lot of people talked about how, things happen. There's like an average of 1 overdose a day at the site. Having a debrief at the end of the day and having people check in was something that people were really looking for at the time. Some inventory. I mean, they couldn't sort of keep enough oxygen there for a time, and so they needed to improve some of that as well. Hosting listening sessions with guests about their feedback, because they certainly had feedback and they gave us a lot of that feedback as well. There's a protocol that was in place that basically the city required them to call 911 for every overdose, which is just not necessary in any kind of way, because people are being revived right then and there. And then, creating an opportunity for guests to participate as volunteered or paid workers was also something that was brought up, and we thought that was an important thing to add to it. So I'm gonna just conclude with the last couple of little things. I did say I was gonna look at cost effectiveness. There have been some studies of this around the US. In San Francisco, we did one where we basically found that if you placed, and this is at the time, if you placed one like they had in Vancouver, exactly the same kind of site, but with the dollars and things going on and staffing in San Francisco, it would essentially have a net savings of $3.5 million a year. So that's amazing. Baltimore did a similar analysis showing almost an $8 million annual savings. And Providence, they compared an OPS to, if you open an OPS to a syringe service program, and found it would be $1 million in savings compared to that. And then New York also did similar kinds of analyses, looking at both one site, or if they had 4 sites at one point, between $1 million and up to even $6 million would be saved. So just to summarize, the science is rigorous, it is extensive. Every peer-reviewed paper out there has found positive impact and no negative impact of these sites, both on the people who use them and in the places where they're placed. I think that's pretty tough to say. I mean, all of you who are working in substance use, addiction, and all that, like, how many interventions can we say that for? Can we say that for methadone? Can we say it for? I mean, what can we say that for, really? You're going to have negative studies on both sides, but here there hasn't been any negative studies, and I think that's remarkable. So I just want to finish by acknowledging so many of the co-authors. This is not just my work, but so many people, all these projects, and also these organizations specifically. We worked with both in the unnamed city, obviously, and also in San Francisco at these sites, Health Right 360, Code Tenderloin, Urban Alchemy were places that people that worked at that site, and so they were great. And then, of course, we want to fund. This wouldn't have been possible without the support from Arnold Ventures, who funded the main study there, and also San Francisco Department of Public Health, who funded the San Francisco study. So yeah, that's it.
Hey, guys. A great talk and really great work. Really striking that there are no deaths. And I would assume that, the guests that are coming into these sites would prefer not to overdose as well. I wonder if you could talk about that and talk about, like, is there any thinking about whether these sites are going to develop ways to reduce the number of overdoses that are actually occurring at the sites?
Yeah, it's tough to have a counterfactual, right? So it's like, okay, so if this person didn't go to the site, would they have overdosed in the community or not? You know, we don't know. You know, we have looked at sort of the rates of overdoses per use, and I think I had that in the New England Journal paper there, sort of per use. You know, there are aspects that clearly make it better for them on this issue in the sense that they don't rush their drug use. They don't have to rush their drug use, right? So if you're out in the street, you're afraid that a family's gonna see you or a cop's gonna come or something like that, you're gonna rush it. And if you're rushing it, you might take the whole, you know, shot in one go essentially, which is too much, rather than taking the time to maybe taste a little bit, do a little bit first, a little bit more, and then maybe to do all of it. So by dint of having the time to do it there, I think that does reduce the likelihood they're gonna overdose at all. And there is certainly education, there's people there to help them with things. But ultimately, you know, the majority of what's going on is just an unregulated drug supply here. And what can you do about that? There are sites, I know the New York sites, for example, you know, they have these FTIR drug checking machines. And so you can choose to, before using it, you can choose to test your drugs to see if they contain what you think they're gonna contain, or if how strong they are. You know, those are costly. Those machines are like $50,000 or something like that. So some places have them. So that's a way to do that. But other than that, you know, people are putting things into their bodies that they don't know what's in there, and it can be too much. And so I think there's always gonna be some overdosing, especially with the drug market the way it is right now in the US.
Thank you for an excellent talk. Lots of questions, but just my one question is, given the documented success of the San Francisco OPS program, I'm just sort of curious what the political backlash was, particularly given the homelessness issue in San Francisco. One would think that there'd be an emphasis on these kind of evidence-based programs.
There are a lot of things that one would think. You know, one of the things we wanted to do, because I think from a policy perspective, you really have two issues here. You have people overdose and people dying of overdose. I mean, that's a big one. And the other, this public drug use piece that nobody wants as well. Which is why we really wanted to do that sort of time study piece to show that we're getting people off of the streets for a certain amount of, you know, here's 18,000 hours a month. And that's something you'd think that everybody would be pro that, like who wouldn't want that in some sort of way? You know, politics are tricky. The mayor made some decisions up front, which was, you know, when the site essentially decided they were gonna open this up, she had a quick decision to make. And I can't speak to how she made that decision or what she would have made that or why she would, but she decided to let it go on. Which was basically what she had a decision to make, whether to do that or not. But she basically put a gag order on everyone working there, such that they let it go on, but no one could talk about it. No journalists, no nothing. It's just as if it wasn't happening. Well, you know, here you are on Market Street, right next to a BART station, a subway station, with a fence that's a temporary fence that you can't see behind. And you got a lineup of people who look like they're probably experiencing homelessness. What's going on behind the fence? What's up? Can't tell you. Well, you know, that lack of transparency, I think, is a big problem. You got ambulances coming because there's overdoses and stuff. The lack of transparency, I think, made the public and the neighborhood really nervous about what was going on. What are you hiding? Something bad. So rather than owning it and saying, this is something that's a public health service, yeah, we realize maybe it's controversial, but we're going to do it. which is how they did it in New York. They literally had journalists and police at their site the day they opened. Anyone can come anytime, and they put a lot of resources on. They have groups. If any of you want to go there, you can sign up online and go for a group, and you can go in and see it. They're like, we're completely transparent what we're doing here. And I think that lack of transparency, I think, created a backlash against it, as such that it was no longer a tenable situation politically.
I have a question online. Do you believe this model could be adapted and delivered effectively via a mobile unit, particularly in response to hotspots of poisoned drug supply?
Yeah, definitely, and it has. There are mobile units in the world. There are places that have mobile units. So that's totally a doable thing. It's particularly a good way to go in rural settings where it's tough for people to get to places, or there's large geographical distances. And at the same time, it's an interesting intervention in that it really works when you're there, but when you're not there, it's not working for you. It's not like it's providing you some protection out and about when you're not there. And so having a site that's there and always there is an important component of it. But that's not to say that if it's a mobile site that goes to hotspots or so forth, that they're, no matter where they are, they're doing good work. And it is an important thing to do. But ultimately, you got to look at it. And if you even looked at sort of the data that I showed, in the unnamed site, the number of injections, they're still doing so many injections that weren't at the site. And so they still have a bunch of risks out there, right? So I think that's one of the issues is, you really want to be able to have it in a place that people can do a lot of their drug use at, so they can be, monitored for a lot of it. But yeah, no, you can totally do mobile sites, and they have those.
Any other questions?
Thank you so much, Alex. Just brilliant work. It's really an honor to hear this presentation. You mentioned how OPSs globally look at the same. Maybe one addendum to this are OPSs and harm reduction services for women, trans, and gender diverse people. I'm just curious how you accounted for gender and other diverse needs in your evaluations, and if not, maybe other future work in this direction.
Yeah, that's a really important point. Vancouver has a women-only site, which is great. In general, what I have observed, evaluating harm reduction programs, that whenever you open a women's site or for women and trans, it's popular. It's a good thing, and so they should have more of those sites wherever you go. We discussed this with the San Francisco site because we talked to women and we interviewed women, as well, and they said it would be nice to have some hours. So we suggested to the management saying, hey, look, how about having some hours that are just for women and trans people? They didn't get to that point. It was only 11 months, and they were really, they started on just, okay, let's open one. And throughout that 11 months, they really evolved a lot to a great model by the end of it. And I think they would have probably, incorporated that if they'd had more time and resources to do that. But I think it's a really important thing to do. For our analyses, making sure that we're interviewing, women as much as we are men and trans, and there are certainly people who are trans in both our qualitative interviews in that San Francisco site, but then also looking at the cohort study for the unnamed site. We certainly had gender diversity there. We didn't see, any statistical differences between women and men. We didn't have enough of a sample size for people who are trans, but we didn't see any change there. But that doesn't mean, that's sort of like, does it work, does it not work, right? But that's not the same thing as, could more people come, right? I mean, would more people feel welcome? What kinds of services might women or trans people need that or want that are different than what men need or what the main sites have? So I think it's an important point and one that needs to be considered wherever you're doing these sites, and then not just these services, but any services, frankly.
I'm gonna go to one on the line. This pertains to possible surveys that you may be doing in the evaluation, either in New York or cohort studies, but do you have survey data on self-reported mental health of those but participated in the OPSs versus those who did not, as it seems there would be positive benefits for participants.
Yes, we have asked those kinds of questions. It's difficult to ask questions about mental health, which we do, but, I don't know that we've examined at the unnamed site, whether we examined that data. I can't remember if we have, and we certainly should. I think that's a really good idea, to do that. So much of what doing the ethnography that was happening at the site, the San Francisco site, was really helpful because we got to see and there was a lot of people with mental health concerns there. Having that radical hospitality philosophy was really, really incredible. But they also had harm reduction therapists, because there's an institution in San Francisco that does therapy specifically for people using drugs. And so they had psychotherapists on site. I think they started sometime around June there, I think it was, or something like that. And so they did have therapy on site as well, and they could connect people to other kinds of services as well. So I agree that this is a good thing for people who have mental health concerns.
Maybe time for one last one in the room?
I got one.
No, I talk them all the time.
Thank you. Sorry I was a little late. I thought I was at USC for some reason, but I was wondering if the Berkeley Free Clinic was related to this, because I understand they did something similar about free needles and stuff. I'm from the Bay as well, so just wanted to ask if that was something that was looked at when creating the OPS.
Yeah, the Berkeley Free Clinic is a wonderful clinic in Berkeley. They have a syringe service program at there that they've had for since 91.
At least, yeah.
Since 1991 or something like that, a syringe services program there. That's really good. It's a unique program. It's run by a consensus model, which is a really great, interesting way to run services like that. But they weren't involved in OPS specifically, and as far as I'm pretty sure they have not done overdose prevention site there. Certainly not that I think I would know.
It's like a harm reduction model.
But it's a harm reduction model, yeah, and they're providing syringes to people and other services too. I mean, it's a medical clinic. They have a lot of different services there, and it's a really wonderful program.